Welcome. Thank you for coming this morning. I'm Ken Beckman. Today, our discussion is called Current and Emerging Treatments for the Management of Ocular Surface Disease, Targeting Mites and More, which is a great breakfast time topic. Again, I'm Ken Beckman. I'm a cornea specialist from Columbus, Ohio, and these are my disclosures. Our esteemed faculty that I am so excited to be working with today. First is Dr. Deepinder Dhaliwal from Pittsburgh, and she'll introduce herself again when she comes up here and her disclosures. And Daryl White from Cleveland, Ohio, his disclosures. This is an educational activity provided by MedEdicus, our sponsors of today's event, which is Taya and Tarsus, so appreciate their sponsoring this event. It is CME for 1 hour. Our learning objectives after this activity, you should be able to implement best practices in the diagnosis of blepharitis, review relevant clinical data on treatments for blepharitis, and develop individualized treatment plans for patients with blepharitis. We will be discussing some off-label material as well. Our agenda, I'm going to present a case, then Dr. Dhaliwal and then Dr. White will present their cases. Now let's start with our cases. The first case, optimize then incise. So this is a patient who I saw was referred to me for cataract surgery with a toric IOL. In the history, he was concerned about his decreased vision and difficulty reading, but he noticed that the reading was getting worse at the end of the day. He also was complaining of dry eyes and irritation, and he was getting a lot of mattering and tearing in the mornings in particular. On slit lamp, he was found to have thickened meibomian secretions with plugging and a lot of debris in his lashes and a rapid tear breakup time. When you look at his topography, this is really interesting. On the picture on the left, you can see while he has 3 diopters of astigmatism, oblique astigmatism, it's irregular. You have that hot spot at 1 o'clock. So he's got 3 diopters. If you then look on the right at the placido images, in the corresponding location, there's a divot in the rings, so they're not completely circular, right in that same area where the hot spot is. So prior to proceeding, just like any of my patients, I like to make sure the surface is treated. And the question is he really a toric candidate? So what was my plan? We're going to treat these 2 things, the lids and the dry eye. Started him on warm compresses and lid scrubs, preservative-free artificial tears, a 2-week course of azithromycin, and I had him come back in 2 weeks. The reason I chose azithromycin, this is one of the interesting articles. There are a lot of these that came out over the years after this product came out, and this one is from our good friend Jody Lux, looking at patients with posterior blepharitis, and they compared azithromycin with warm compresses to warm compresses alone. And what he found in a period of 2 weeks was significant improvements in plugging, meibomian gland secretion quality, and in eyelid redness as in the azithromycin group versus the warm compresses alone. Overall, much better symptom relief, and there were no safety issues. The other thing I mentioned that I was doing was starting him on preservative-free artificial tears. We know preservatives are in many drops to maintain sterility and extend shelf life. BAK is the most common one. It's in over 2/3 of these, but it has cytotoxic effects and it can worsen ocular surface disease. So a preservative-free is going to be less cytotoxic. Some of the limitations of preservative-free, that was the cost, the availability, and the risk of contamination. So let's look at hyaluronic acid, which is a major component in artificial tears. What the HA does is it surrounds the water groups with its hydroxyl groups, and it thickens and stabilizes the mucoaqueous layer. And what is trehalose? Trehalose is a natural sugar with bioprotective properties, and we now see it in an artificial tear. It stabilizes and refolds proteins that are misfolded during oxidative stress. It activates autophagy, reducing inflammation, promoting cell survival. It's safe, it's not toxic, it's well tolerated. But most importantly, in some of the clinical trials which we actually have with artificial tears with trehalose, it improves tear film stability. It reduces corneal and conj damage, increases goblet cell density, decreases pro-inflammatory cytokines, and relieves dry eye symptoms. And this has been shown in multiple clinical trials. Trehalose, we have seen, extends the positive impact on tear film thickness in drops that have hyaluronic acid. So when you look at the graph here, the bottom line is just saline, the middle one is hyaluronic acid, and the upper one is hyaluronic acid with trehalose. And you're looking at the relative change in tear film thickness, and you can see that it just stays on the surface and maintains thickness to the tear film. Other things we know about this, it's significantly, the trehalose-containing hyaluronic acid drops significantly outperformed HA drops alone in the OSDI score, which is a symptom score, after 84 days in patients based on, in patient groups based on OSDI class. And it matched or improved the HA drop performance in patient reported symptom severity. So we're seeing it as a nice enhancer to the hyaluronic acid alone in an artificial tear. So questions for our panel. First, what features do you look for when you're selecting an artificial tear? Deep.
Thanks, Ken. I think it's really important for my patients, at least. I want preservative-free as much as possible. And now I want a brand name artificial tear. I do not want them to go and get whatever's cheapest at, CVS or Walgreens. I want them to get the brand name because of all these issues that we're seeing with these generic medications. So I'm very particular now in terms of, what they're getting and how they're using it. And I have to say, these trehalose hyaluronic acid drops are game-changing. They feel amazing, they last long, they don't cause as much blur. And if you can get a preservative-free drop in a bottle, because the bottle has a little filter in it, what more could you want, right? Because then patients can have the convenience of a multi-dose situation, but in a preservative-free formulation. So that's really what I look for now. So when I'm recommending tears, I'm very particular about that.
Any comments, Daryl?
I always have comments, Ken.
I know. Why don't you answer the second question? How does frequency influence your preference for preservative-free tears?
So once upon a time, there might have been multiple answers to that, but right now the answer is it doesn't influence my preference at all. I want preservative-free drops every single time. The brand thing has been kind of like a non-starter up until the last couple of weeks. How many of you have heard of Dr. Glaucomflecken? Right? So Will is very obvious. We joke about the branded drops that get the red eye drops out. There have literally been 2 homicides that have occurred by using a get the red out drop to poison a philandering spouse. Now, what Will says is that if it's not a brand, it can all kill you. So, brand, everything Deep said about the trehalose and the hyaluronic acid, and if you're at all thinking about doing surgery, you don't want to add to the toxins on the surface there. It's got to be non-preserved. It doesn't matter how many times they're putting it in.
Right, thank you. Traditionally, we used to say if it's 4 times a day or more, you should probably be preservative-free, but now there's so many good available preservative-free drops, particularly in a bottle, that I go for that right away. Okay, let's go back to that case that I showed you before. After treatment for 2 weeks, again, warm compresses, preservative-free tears, and azithromycin drops, I found improved meibomian secretions, improved conjunctival and corneal staining, and improved tear breakup time. So just as a reminder, here's the original topography with 3 diopters of oblique astigmatism. Here's his post-op. He's now down to a half a diopter. The placido rings are perfectly spherical. And head-to-head, you can see this. So now, does the guy get a toric? Obviously not. Had I put in a toric for 3 diopters of oblique astigmatism, we'd be in a lot of trouble afterwards. Then the next question is he even a presbyopic IOL candidate? I personally do not like using them in these. Part of my concern is, yeah, I can get him cleaned up today, but is he gonna stay cleaned up? And I don't know. So yes, you can if you're comfortable with the long-term maintenance of these patients. I chose to use a monofocal aspheric lens in this patient. So what are the risks of having a poor surface prior to cataract surgery? And I always like to talk about 3 things. The obvious one, we know perioperative infections. But number 2, inaccurate IOL calculations, which you just saw. We would have had a disaster had we used that lens. And then number 3, the one that people tend to forget about is the postoperative visual aberrations. So I have a patient like this, they get their multifocal lens and they're happy in week 2, and then gradually they stop taking care of their surface and they're miserable. So this is an ongoing thing. Suboptimal visual outcomes and patient satisfaction. These are the risks. So the lesson learned, you need to optimize the surface before surgery. What are the indicators of a surface problem? Listen to the patient. This patient wasn't just complaining of blurred vision, it was getting worse at the end of the day. So, cataracts tend to not get worse by the hour. The people who come in and say, I can read for an hour and then it gets blurry, you want to think about surface. That's surface until proven otherwise. You want a detailed lid margin and tear film examination. And we saw, I was lucky enough to be part of the ASCRS panel that put together the dry eye algorithm around cataract surgery, and we spent an extensive amount of time talking about looking at the lids, pushing on the lids, lifting the lids. It's really critical. I like to get multiple K readings, so I get a topography, I get an IOL master, and I get manual Ks. I like to make sure that they match and that the Myers are regular. And is the vision consistent with the cataract? Sometimes they have a bad surface, and so it might only be a 20/30 cataract and they're 20/80 because of their surface. So you want to pay attention to that. And the take-home points for surgical planning, don't rush into surgery. It may take multiple visits. Sometimes you're delaying them for weeks and weeks and weeks. Use caution with premium IOLs, and remember that the patient education is critical. They will understand if you say to them, we get one chance to put the right lens in your eye, let's get it right, let's take our time. Most of them are okay with that. All right, now I'd like to introduce Dr. Dhaliwal to give us the second case. Thanks, Deep.
Thanks, Ken. Good morning, everybody. Really appreciate you being here. When we put this program together, we wanted to make it full of pearls that you can use, that you can take back to your practice as soon as you get home and really have an impact on your practice. Thanks to Medeticus and Ken Beckman for inviting me to participate in this. Okay, so how many of you, when you see dry eye patient, new consult, kind of get a little bit of a pit in your stomach and just want to run the other way? Okay. Come on, let's hear. And then when you say new cataract consult, right, it's a little bit more exciting. So here's the deal. I'm going to give you some pearls where I used to be just like devastated. And, I used to think, oh my gosh, I'm going to walk in and see this patient. It's going to take me 45 minutes or something. So I'm going to give you some pearls it's going to be like a little kind of coat of arms that you can wear to shield yourself from being depleted by these patients, and you're going to be able to effectively treat them and not have just be exhausted by the end of the day. So here is your patient, 64-year-old man, referred for assessment of severe dry eye. He doesn't look very happy because he's seen 3 previous ophthalmologists. He's extremely frustrated. He's using artificial tears every hour while awake with no relief. He's got some diabetes, rosacea, allergies. He's on oral cetirizine and metformin. And he's also using ketotifen twice a day in addition to the artificial tears. So, Ken, any problem with this every hour while awake frequency of drops?
Yes. As you know, we've discussed this many times. Number 1, preservatives drive me crazy. Number 2, that kind of frequency, you're flushing away all the natural components. I know you've spoken about this many times on the surface of the eye. So yes, I have a lot of concerns about that. And number 3, just the mere idea that somebody needs that much, they need to be on a definitive treatment.
Right on. So here's the thing. Even if it's preservative-free, I find that when people are using every hour drops, they get dishpan eyes. And it's a term that whoever's, kind of remembers Marge washing her hands all the time and getting dishpan hands. It's because you wash your hands, you wash the oils away. So similarly, when you use a tear too much, you're washing the oils, the meibum away, and you get worse. So yeah, nobody should be using a tear every hour, even if it's preservative free. So when you have these patients, what's the best strategy? Well, you got to figure it out. It's not a one-size-fits-all approach. So you do the history, testing, exam, figure out the treatment plan, and discuss. And you can be efficient. So here's the deal. When you walk in the room, never ask an open-ended question like, what seems to be the problem? You have to just say, what are the top 2 things that bother you about your eyes? Okay, even though you know they're there for dry eye. Don't go down that rabbit hole. Just say, what are the top 2 things that are bothering you about your eyes or your vision? And so what's amazing is that these people stop because they don't even really realize. They say, oh, I have dry eyes. I say, I understand that, but what does that mean to you? What's actually bothering you? Then they actually have to think. Sometimes it's the visual fluctuation. Sometimes it's just blurred vision all the time. They think that's, and they have a cataract. So it's interesting how it's confusing to them. So really focus, have them focus, and then you have a strategy. You can impact those things that are bothering them. The other thing I always ask is, what makes your symptoms better? Does anything at all, even if you use an artificial tear, does it help for even a minute, right? Because if they say no, I put a preservative-free artificial tear in their eye. I don't tell them what I'm doing. I say, does that help at all? Even for, just a short time. If they get relief, I know it's something ocular surface. If they still don't have any relief, I put a drop of proparacaine in their eyes. I don't tell them what this is. And if they are still symptomatic and they have been anesthetized, then I know that there's something else going on. Something's deeper, right? They might have neuropathic pain, some type of pain syndrome, that probably all my topical therapies are not going to be as effective, and we might have to do something like gabapentin or something, perhaps acupuncture, something else, right? So the other key question, are your symptoms worse in the morning or later in the day? And as Ken said, later in the day is classic dry eye. If they have symptoms worse in the morning, 4 things you got to think about. Floppy lid syndrome, blepharitis, especially with Demodex, recurrent erosion or EBMD, or lag of thalamus. That's it. Those are the things that make people worse in the morning. So there you go. You have 4 options to choose from. And if they have lag of thalamus, ask them if they sleep under a fan or use a CPAP. And if so, you treat with night goggles or something. So examination. Now this is super important. You got to look at the patient, see how much they're blinking, how much eyelid closure. And can we play the video? Oh, here we go. And then this is the external eye exam. Look up, look down, look left and right. How long did that take? Like 5 seconds? Look up, look down, look at those floppy eyelids. Ay, ay, ay. Look left and look right. That information right there is basically will give you so much of your exam findings. Why? Because when you pull the lower lids down and have the patient look up, you will diagnose conjunctivitis in 5 seconds because the hyperemia will be affecting the bulbar and tarsal conj. This is my son with problematic allergic conjunctivitis. Okay, so you can see it's conjunctivitis. The other masquerader that we often see referred in is mucus fishing syndrome. And this is a chronic conjunctivitis that's really secondary to like a mechanical irritation. So my tip-off is I'll see a little stringy mucus in the lower fornix. And it looks kind of like allergic conjunctivitis, but it's more chronic. And then I gently ask, how, that mucus must be super irritating. Yeah, how do you get it out? Oh my goodness. When you hear how these patients, they sometimes take their long fingernail and they go into the lower fornix and up in the upper fornix, or, they do these things and they're chronically mechanically irritating their eyes. And oftentimes you have to just ask, and then you have to gently have that patient education. All right. And if the hyperemia is just limited to the bulbar conj, it's episcleritis or scleritis, okay? So now this is a picture from Ken Beckman. This is the worst floppy eyelid I've ever seen. It's kind of too early in the morning to look at that too long. So
it's my patient.
It's not Ken's eye. Oh, okay. It's his patient. All right. Anyway, the key thing, because I want to change the slide as soon as possible. Floppy lid syndrome is a problem because the upper lid everts at night when they're sleeping. Okay, just like that. And it causes a lot of irritation in the morning. So remember to ask these patients about sleep apnea and look for keratoconus. Those 3 things go together. Floppy lid, keratoconus, sleep apnea. Also, when you look, have the upper lids up and have the patient look down, you're going to diagnose SLK. And remember, that's associated with thyroid. So now, this is absolutely critical. You have to have the patient look down. This is super, super important. 2 things to focus on. One is this nasal lash displacement. All right, when you see that, you know the patient is pushing on that side of their face. And you're going to look like the smartest ophthalmologist because you're going to say, oh, I see that you sleep on, the left side or the right side, whatever side you see this nasal lash displacement. And that is true. That's how it happens. So it's interesting when you look further into the patient's exam, we often see more ipsilateral ectasia on that side. And we're now finding that those patients often have cup to disc asymmetry. So we're trying to really do a deep dive into this. But here's the key thing. You can't miss this now, all right? You have to look at the base of the lashes of the upper lid. This is absolutely critical in 100% of patients. Why? Because you're going to see the collarettes or sleeves, the cylindrical type of waxy dandruff on their lashes, okay? And this is a sign of Demodex. The other part of the exam that's really important is I use a fluorescein strip and put it in the eye and have the patient, I use a diffuse blue light because, this cornea looks pretty healthy. However, when you look, you can, assess EBMD when you look with a diffuse cobalt blue light. So always do that. Put a little fluorescein in. You can see the staining of the conjunctiva of the cornea and that. So back to the patient. So his itching was first thing in the morning. He was bothered by chronic redness and foreign body sensation. So those are the 2 things he told me. When I look on the exam, he has raging Demodex. So when you see those, those kind of those waxy collarettes or those sleeves that we used to call them, that is a sign of Demodex blepharitis. He also had low tear lake, rapid tear breakup time, and MGD. What is Demodex? All right. I'm just going to play this video. I know it's early in the morning, but this is very interesting. That is taken by my previous fellow, Lorenzo Cervantes. This is a lash that we plucked, we put under the light microscope. This is Demodex. This is crawling on your patient's eyelids. It's pretty nasty, all right? So what do? They're super annoying. They're these collarettes are the waxy in texture. They're composed of undigested material, keratinized cells, dead or living mites. And why do the patients have symptoms in the morning? Because the little mites come out on the lashes to mate, and then in the morning when the light comes on, they burrow back into the lash follicle. And you'll ask these patients, and they'll notice, yeah, I'm itching first thing in the morning. It's super irritating. And that's the little bugger going back into the lash follicle. So that's why they have that. Now, the itching is not allergy. This is a separate type of itching. All right, this is Demodex. So really, we need to know a little bit more about this because we need to be treating our patients for this. This is very prevalent. So there's 2 types, lots of risk factors that are very common in our patients: rosacea, diabetes, increasing age, stress, smoking, immunosuppression, higher alcohol intake, and greater sun exposure. So we often see the comorbidities like dry eye, MGD, chalazion, blepharoconjunctivitis, and these Demodex mites, they regurgitate some undigested material, which is very pro-inflammatory, like proteases, lipases. Prevalent, very prevalent in all these patient populations that we see. Over half of our patients will have Demodex blepharitis. All right, so that, you can see this is another slide from our Campbell lab looking at all those mites around that lash follicle. So how are you going to treat this? It's got to be targeted. And I'm so excited that we now have an FDA-approved treatment for Demodex blepharitis, and that's lotilaner, 0.25%. And it's a simple BID drop. So it's not like you have to, have ointment all over the eye. It's a drop. Everybody can use a drop twice a day. I used to use tea tree oil, which was pretty irritating after a while, or I used to have patients like suffocate the mites with ointment. Some people use oral medications as well. But this is something that we need to now really recognize and treat effectively. So I want you to learn a new grading scale. This is how to grade the collarettes, or that cylindrical sleeves on the lashes. So it goes from grade 0 to 4. 0 is less than 3 little lashes with the collarettes. Grade 1 is up to 10, 3 to 10. And then grade 2 is about 50. Grade 3 is 100. And grade 4 is 150 lashes with those collarettes. So that's a lot, right? So basically, if you're grade 0 or 1, that's pretty good. That's basically a clinically meaningful cure. And that's important when we talk about the data about lotilaner. And this is really exciting data because lotilaner achieved regulatory endpoints of complete collarette cure, so less than 3 lashes affected with the collarettes in both pivotal studies. It was Saturn 1 and Saturn 2. But you can see there was statistical significance as soon as day 15. So you can tell your patients, in 2 weeks, you're going to start noticing an improvement. But truly, the treatment out to 6 weeks is what's necessary to achieve that really nice cure. And in terms of a clinically meaningful cure, that was achieved in 90% of patients at 43 days. What's nice is that it's super well tolerated. So something so effective can sometimes have side effects, not this drop. It was really, really well tolerated. And what's amazing is when you look at the drop versus the vehicle, it almost looks like in some cases the drop was more comfortable than the vehicle. So that's so nice to see. And that continues over the course of a 6-week treatment time. So in general, these people with dry eye deserve to be heard and treated appropriately. Let's just take the time, make the diagnosis, treat it appropriately so these poor patients don't get in that vicious cycle of seeing, all these different ophthalmologists and being super frustrated. So just taking a stepwise approach to these patients is very helpful. Target the history, do that careful slit lamp examination, that also that external eye exam. That's really all you need to make a diagnosis and formulate a treatment strategy. Remember to have everybody look down and just look at the base of the upper lashes. Now we can effectively eradicate Demodex. And the critical thing, as Ken mentioned, optimization of the ocular surface prior to cataract or refractive surgery is critically important. Thank you so much for your attention. Daryl, thanks. I'm going to pass the baton to Daryl, who's going to just conclude with our third case, and we'll have time for discussion. Thanks.
So I didn't read any of the fine print for this morning's meeting. I always say yes to Ken. I always say yes if Ken invites Deep. But the second part, in addition to having to be here at 3 o'clock in the morning, because Ken's really, really excited, he didn't tell me I had to follow Deep. That's one of the hardest things possible. So we're going to talk about a case that comes into your office all the time, and we're going to talk about how can we treat these patients, get them to feel well, and continue to feel well. Because Ken's finished his surgery, but the patient still has dryness that needs to be treated. Deep has treated the Demodex, but the patient continues to have some problems. So I'm going to present Mark. Mark is a 59-year-old man who moved from Pittsburgh to Cleveland. He has, I live in Cleveland. Deep lives in Pittsburgh. Ken lives in Columbus. This patient has a long history of MGD and blepharitis. He's seen at least 7 ophthalmologists prior to coming to see me and prior to coming to see Dr. Dhaliwal. Dr. Dhaliwal treated him with daily heating of his eyelids, lid hygiene, oil-based artificial tears. She confirmed the diagnosis of Demodex blepharitis. She treated his Demodex blepharitis and eradicated the Demodex, making him a much happier man. Following that 6-week course, just before he was able to see her back so that he can congratulate her on the great work that she did, he moved to Cleveland to improve his allergies. It turns out that he was on daily antihistamines because he was allergic to Pittsburgh. Can't make this stuff up. So, Deep, I've now got your patient. You've crushed it on the Demodex. How am I going to change my algorithm taking care of this guy? What am I looking for? What am I honing in on now that you've already taken care of his Demodex?
Daryl, first of all, thanks so much for taking care of him. I really appreciate it. You're always the best. So here's the key, right? Demodex does not really exist in a vacuum. There's always other stuff. So inflammation is so common in these patients. We have to tackle that. And also, oral antihistamines dry the eye 150%. So what we try to do is take people off systemic antihistamines and instead treat their allergy locally with drops or nasal spray or inhalers, et cetera. If they need something systemic, we often switch them to singular as opposed to an antihistamine because that does not have as much ocular drying.
So thankfully, I am a Deep Dhaliwal acolyte, and I know all that, so I'm going to follow her instructions really to the letter, but I'm going to dive a little bit more deeply into his history. Turns out that he had LASIK performed by Dr. Beckman in 2008. He was the last LASIK patient that Dr. Beckman ever did. He was diagnosed with primary open-angle glaucoma 4 years prior to being seen by Dr. Dhaliwal. And he'd been treated with generic latanoprost since diagnosis. Ken, what do we know about generic latanoprost? We've talked a little bit about this in terms of the artificial tears.
There are a lot of preservatives.
A lot of preservatives. Always be on the lookout for the preservatives and whatever else your patient happens to be taking. Now, his diagnosis has been made and his treatment's been quite good. His pressure's been stable at 17 in both eyes for at least 2 years. There's been no change in his OCT or his visual field. So we know that from a glaucoma standpoint, he's actually doing fairly well. So now we do a deeper dive into his social history because we're dry eye docs. We want to make sure that we know what the other kind of co-conspirators and the co-instigators are. He's an accountant. He spends approximately 6 hours a day, 5 days a week on his computer. He wears bifocals when he's on the computer, and he wants to know why Dr. Beckman's LASIK stopped working because he has to wear glasses again. This is why Dr. Beckman stopped doing LASIK. He's a diehard Cleveland sports fan, which is why he moved back to Cleveland. He watches the Browns, the Guardians, and the Cavs. And when he's playing video games, because he's a gamer, so again, on screens even more, he always chooses to play as the Browns, Guardians, or Cavs. He doesn't smoke. He drinks alcohol only when he's watching the Browns, Guardians, and Cavs. And his diet is a typical middle American diet. Seafood, buy food, cook food, eat food. There's nothing special about his diet. His medical history is unremarkable except that he's a former collegiate distance runner at the Ohio State University. And he proudly notes that his resting heart rate is still in the 50s. A lot of foreshadowing here. Speed test, it's 11. Anything over 6 in the speed test is abnormal. His tear osmolarity is 274 in the right and 293 in the left. Osmolarity is a really interesting thing if you really, really study it. There is no normal or abnormal. There's only high or low, symmetric or asymmetric. He's got a low tear osmolarity, so we know he probably doesn't have aqueous deficient dry eye. He's got asymmetry, so we know he's got loss of homeostasis. So we know that he's got a problem on the surface of his eye. His MMP9 is strongly positive in both eyes. We do meibography and we see severe obstruction, truncation, and structural alteration, and signs of lipid congestion. And this picture is courtesy of our friend Alice Petropoulos, also from Columbus, Ohio. And what we see some gland destruction in the mid-lid. All of those glands are shortened. And we also see very clearly the central duct in the meibomian glands. And we shouldn't really see that. So we have some congestion. Priya Gupta came up with a phrase which I think is absolutely great. This is meibomian gland constipation. On the clinical exam, he's 20/20 plus 2 in the right, 20/20 in the left without correction. Dr. Beckman's LASIK didn't stop working. He just went and got older. He's J1 plus with his readers. Pressure by aura is 22 in the right, 21 in the left. By applanation, 17 in the right, 17 in the left. His hysteresis, which you automatically get with the aura, is 10 in the right and 11 in the left. How many people know what the aura is? Okay, that's 2 more than I expected. Aura is not your daddy's NCT. You get hysteresis, which is a measurement of the flexibility of the cornea. In every single patient, hysteresis gives you a risk factor for that particular pressure. High is good, low is bad. It's the opposite of pressure. He's above 10 in both, so the pressures that he has are indicative of actually low risk. On slit lamp, 3+ posterior blepharitis, dense telangiectatic vessels, thickened oil and expression, no collarettes, because he was one of Deep's patients. His conjunctiva is sticky, there's some injection, fluorescein staining on the conjunctiva, which is another place that you should always look when you're looking to see if the patient has dryness. And he's got clear flaps, good job, 1+ SBK inferior and 2+ SBK inferior in the left eye. Tear breakup time is 3, wildly abnormal. A normal tear breakup time is 8 to 10. A tear breakup time doesn't have to be complex. It's great if you have something that does a non-invasive objective tear breakup time. Almost nobody does. So you essentially put in fluorescein, get that wide cobalt blue light that Deep was talking about, and then you count. What you choose to count kind of depends on where you come from. If you come from Big Ten country, you might count 1 Ohio State, 2 Ohio State, 3 Ohio State. If you're from the SEC, of course, it's 1 Mississippi, 2 Mississippi, 3 Mississippi, because nobody ever says Alabama. His iris was normal. His lens had a little bit of nuclear sclerosis. I'll be here all day. Make sure you tip your waiters on the way out. And his gonioscopy, I was unable to obtain his gonioscopy because he had vigorous squeezing and was literally backing away from the slit lamp. Here's another picture courtesy of Alice. He's got, as you can see, about 1+ inferior corneal staining. This is really, really classic for evaporative dry eye. It's especially classic for evaporative dry eye when you see patients who are living the digital lifestyle, a phrase which I think Netashami gets credit for. People who live on screens, which is to say every employed American in the United States. We wouldn't have, we'd all be out of a job as dry eye specialists right now because 86% of patients have evaporative dry eye, and the vast majority of them have that because they spend all day on screens. If we didn't spend time on screens, we wouldn't have a job. We'd still be cataract surgeons, and Ken might have to do LASIK again. Can we play the video? Up. And here is what this guy's oil looks like, again, courtesy of Alice. Hey, that's abnormal oil. Hey, it's supposed to look like peanut oil or vegetable oil or olive oil. So, all 3 of us have managed to ruin your breakfast. So, Mark has severe posterior blepharitis and meibomian gland disease in both eyes. He clearly has an evaporative dry eye. He's got early nuclear sclerosis, but he really doesn't have any vision problems per se, except for the fact that he's old enough to need to wear reading glasses. He's got early primary open-angle glaucoma. Treatment goal has been achieved, and he's status post-LASIK. So what's our plan for this guy? Because he's still uncomfortable. Well, first of all, we want to change him to a non-preserved latanoprost. He's clearly well controlled on latanoprost. There's no reason to move away from the basic medication, but we now have the opportunity to treat patients with non-preserved latanoprost. How about SLT? Well, I would normally take this guy to do SLT, but I can't even do gonioscopy on him because he's squeezing like the devil. There's no way I'm getting a lens on him. There's no way I'm going to get him to sit at the slit lamp long enough to do an SLT. How about injectable metaprost? I think that's a great idea. It's a super way that you can give the anterior segment, the surface, a little bit of a break. I'm not sticking a needle in this guy's eye. I can't do gonio. So what we're going to do is use topical therapy. How about switching him to non-preserved timolol, for example? It's a great idea, but if you remember back to his social history, he's very proud of the fact that he was a runner at the Ohio State University, and his resting pulse rate is in the 50s. You knock that down a little bit with the beta blocker, and maybe you've created a medical problem. We're going to discontinue his oral antihistamine, except, oh, he moved to Cleveland. He's not allergic to Cleveland. He already stopped it on his own. He was allergic to Pittsburgh, so I don't have to deal with that. Come on, that was good. There's some low-hanging fruit here. Encourage lid heating, encourage hygiene with over-the-counter scrubs, nutritional therapy, reesterified fish oil, blackcurrant seed oil containing medications, and then the anti-inflammatory diet. I think this is underappreciated and understood. Keto diet, the carnivore diet. Rotoyos has in his book an anti-inflammatory diet. It depends on how deeply you want to get into these things. This guy might respond to that, having been a former big-time competitive athlete. But for him, the big deal thing is that he has surface inflammation. We have to treat his inflammation. We have to treat the inflammation that's still deep within his glands, and we also have to treat the inflammation that's on the surface. So we have two long-term treatment options. We have cyclosporin, and there are multiple options there. We have two branded cyclosporins, and we have multiple generic versions. Interestingly, almost all of the generic cyclosporin, 0.055%, is actually made by the company that made the original brand, so you're really not even getting a generic there. And then lifitegrast. How about a topical steroid? Okay, I personally think that the fastest way to get your patient in a ready-for-surgery treatment mode, if you're doing cataract surgery, they have dry eye, can be summed up in 2 words: steroids. Put them on steroids. Adjuvant therapy for treating the inflammation, adjuvant therapy to get them going on their immunomodulator, rapid treatment if you're getting them ready for surgery. Any concentration of loteprednol, any formulation of loteprednol, I think is exactly the same as the immunomodulator market. Ken talked about putting the patient on whichever one is best covered by their insurance. That's the first shot across the bow. At the end of the day, access is the biggest challenge that we have to getting these people treated. Do yourself a favor, treat yourself, try to do the easiest access for that. Fluorometholone is actually brilliant. In the FDA phase 3 trials for fluorometholone, the original fluorometholone was investigated head-to-head with branded Pred Forte, and it came out as potent with fewer complications. How about topical azithromycin? Ken talked about the azithromycin in Jody Luck's study. This is a brilliant treatment for the chronic inflammation that comes from the meibomian gland disease. Topical azithromycin in a proprietary delivery vehicle has enhanced surface duration, high tissue penetration, and a long duration at tissue levels. The possible mechanism of action, we know that azithromycin reduces MMP9 activity, so that entire inflammatory pathway is downregulated. You lower the melting point of the meibum, so the meibomian gland secretions are coming out in a liquid form at surface body temperature after treating with azithromycin. So 1% sterile aqueous topical azithromycin in that proprietary delivery system of polycarbophyl, edetate disodium, and sodium chloride. It's indicated by the FDA for the treatment of bacterial conjunctivitis caused by all of these organisms, and the on-label administration is 1 drop twice a day, 8 to 12 hours apart for 2 days, and then 1 drop in the infected eye once daily for the next 5 days. But that's not why we're using it. We're going to use it for the treatment of blepharitis and meibomian gland disease. And here are 4 studies: John, Lux, Haig, Aptes, or 5 for those of us who can count. Did I mention that I don't count very well at 03 in the morning? And Gary Fox. And what they all show is that there's an enhancement in the quality of meibomian gland secretion with the chronic usage of azithromycin. And we can see this as early as 4 weeks following the institution, as we see in the 3rd study. it relieves symptoms as early as 4 weeks. We all know that the blepharitis doesn't go away, so you're looking to use this chronically. How does it work? Azithromycin suppresses the bad cytokines and chemokines, IL-1B, IL-18, MMP9, and it increases the good cytokines, TGF-1 beta, for example. Laura Perman calls this the good witch of the West. So we treat the meibomian gland inflammation. We can use intense pulse light therapy. The possible mechanisms of action here are constricting or closing those telangiectatic vessels. It reduces the release of pro-inflammatory cytokines, increases ATP production in the gland cells. You thought you didn't really need to know the Krebs cycle. Ha! All of our professors were right. And it can be performed with the eyes closed and shielded, so I can do that for the patient. IPL and expression improves the signs of dry eye. You have a reduction in the rapidity of the destruction of the glands, and we can see this on straight up biomicroscopy. We don't need to use meibography to see that. So how did Mark do? 3 months post-IPL, lifitegrast and topical azithromycin, which we now have him on every other day because remember there's a long duration. His speed score went from 11 to 5. He now has only 2+ posterior blepharitis. His meibomian gland secretions are no longer thick, but they're still a little bit milky. We know he needs to be continued to be treated. His conjunctival staining is now only trace. His SBK is now trace inferior only in the inferior third in both eyes. His tear breakup has gone up to 4. He only has occasional burning, and he still has some fluctuating vision. But he really wants to know why it is that even though he came back to Cleveland, the Browns and the Guardians still stink. But he has high hopes for the Cavs this year. So I'm going to turn it back over to Ken.
Daryl, that was great. As expected, you were the only panelist to go over on your time.
3 seconds.
Yes, so that was really, really exciting. You know, there were so many interesting points. Daryl talked a lot about preservatives, but specifically with glaucoma, and I think this is a really important thing to think about. We get patients who have other problems, and we're so focused on what they're here for. They're here for their dry eye, but we know that about 60% of glaucoma patients are going to have dry eye. They're just pouring chemicals on their eye. And so thinking about toxicity from drops is really important. You're doing such a service to them when you can think about ways to get them off of the preserved medications. One interesting thing, he showed the inferior staining. But one thing that you see commonly with medicamentosa and toxicity from these drops, if you do conjunctival staining with lysamine green, you'll see that the concentration of the staining tends to be inferior nasal, where the punctum is. Because what's happening is the tears are just kind of going downstream and draining down the drain. So when you see that, that is the hallmark sign for toxicity from drops, and that's an indication to say, what can I do to limit the preservatives? We'll answer questions.
So Daryl and I have been kind of sifting through them. So go ahead, Daryl. Yeah.
All right, so there are, I think, 72 people here. We have 74 people who want to know what is the long-term treatment plan for Demodex in terms of recurrences? How often does it need to be repeated? When does it need to be repeated? So the reality is that in the 2 phase 3 trials, there was not any research done on those specific questions. But we all know that Demodex doesn't go away. We're just treating the Demodex that's at the base of the eyelashes. Demodex is, it's kind of like, it's the skin version of gut flora. Demodex is everywhere in our bodies. It's a totally non-factor unless they get into the eyelashes. So we have to assume that they're going to get back. Margaret McDonald talks about telling patients that they should expect to be treated a couple times a year. We don't know that. But I'm going to tell all of my patients when I have patients on lotilaner that they're going to need to be treated again. I just don't know when it will be.
You know, it's funny, I tell patients with styes and chalazion, et cetera, when you pop a pimple, you get rid of the pimple, you don't cure the acne. And I think that's the same thing here. These patients, you're going to get rid of the acute thing that's going on, but you need long-term maintenance.
And a follow-up question, if there's Demodex that's still alive, can you continue treatment with lotilaner? It's super non-toxic, but this is one of the beauties of the treatment that's available for us with lotilaner is that it's a 6-week course, and unlike everything else that we use with ocular surface disease and dry eye, you don't have to continue using it. There's no reason to tell people to continue using it. If they become symptomatic and you see that it's recurred, you can repeat the 6-week course. So that's going to be the universal recommendation from everybody who uses it. No, don't leave them on it. Reevaluate them in 6 to 9 months, and if they require another course, put them on another course.
All right, and there's a question about our protocol for administering warm compresses. So this is part of the art, and if you ask the three of us, I'm sure we have 3 different answers. What I've been using a lot is I use a sheet, and I have all these options listed for the patient. So it starts with, put some rice in a sock, and you can microwave that, all the way down to an electric warm compress that they can get. They order it online, and so they can just plug it in, and they can take it with them on the plane. And in between are the wonderful masks that you can microwave that are made for the lids. Here's the thing, though. I tell patients you need to do it for 15 minutes twice a day. So if I say that, then they'll at least do it for 5, right? So if I say 5, they do it for 1. Yeah, this is my strategy, but I'm telling you that 15-minute time point, I find if they really are very clear about doing that, they will come back and tell me that is super effective for them. So in addition, it's a multi-pronged approach, but that warm compress is very effective when used long enough. All right, Ken, back to you.
I need another question.
Okay.
Oh.
All right, so can you comment on the use of azithromycin oral 1 gram per week for blepharitis? It works, but you're putting someone on a systemic medication and exposing them to the possibilities of systemic complications. The people get GI issues when they take oral antibiotics. And I strongly prefer to use a topical, localized treatment for a problem that is localized. Does it work? Yes.
100% agree. The gut microbiome is super important, and I don't think we should be dysregulating it. So time's up.
Yeah.
Oh, go ahead.
I was just going to say, we have plenty of patients that are chronic rosacea type patients that are using doxycycline or azithromycin. I like this in little pulses because it lasts long. Sometimes I'll say use it 1 week of the month, or 1 week on, 1 week off, or like Daryl said, every other day. Lots of options, just little pulses for maintenance. All right, this was so fun. Thank you guys so much for your attention.
Thank you.
Thank you so much for MedEticus for putting us on, and to Taya and Tarsus for sponsoring this event. Thank you.